years between 2016-2021. The only thing in 2016 they recommend to be 200 mg per day. It can be given OD or QIV, but in 2021 they put more emphasis to put it as 15 g QIV rather than one single bolus. In blood transfusion, both of them, they never recommend any blood transfusion above hemoglobin 7. And regarding ventilator ventilation, they have a recommendation regarding ARDS. For example, in 2016, they recommend a target PO2 of SPO2 94 to 98, and in ARDS patient, they reduce it to 89 to 92. In 2021, they highly advocate for high flow nasal cannula and high flow oxygen and using of non-invasive before going rush to intubate the patient. And this is mess all of us, we practice it, especially during COVID area. We never go rush intubate the patient in COVID, and we are usually delayed for 1 to 3 days depending on the patient condition. So now we'll go to the updates which happened in 2023, and usually these articles are emphasized in treatment of sepsis and septic shock in adult patients in management during emergency department. This is the articles, and it is emphasized or focused more in management strategy in emergency department and highlight a key area for improving patient outcome. And the key recommendations are in the empirical antibiotic, they promote admission of broad spectrum antibiotic is very crucial and should be administered as possible as soon as possible after taking the culture. And they advise to do it in the first hour. In the fluid resuscitation, they again emphasize in using balanced crystalloid for initial resuscitation like ringer lactate or plasmoid, but don't use like hyperchloremic normal saline or any other type of saline in the initial resuscitation. And they highly recommend to give a bolus, then reassess the patient, and they are recommended to use dynamic measure rather than static measure. And maybe Dr. Atira will speak more about it. And they are recommended to use either stroke volume variation, pulse pressure variation, echo to assess inferior vena cava ratio, and finally the leg rising test. In vasopressor, again, they emphasize in noradrenaline to be the first line to maintain the blood pressure above a MAP of 65, and they insist that in refractory shock, vasopressin should be introduced as early as possible. In the previous years, we used to go up with NORAD up to reach the maximum, which is 1 mic per kg, 1.2 mic per kg maximum. But nowadays, they advise that if the patient not responding alone to noradrenaline, if he reach like 0.4 to 0.5 mic per kg, you should add another or the second line treatment, which is vasopressin in septic shock. If the patient are not heart failure or renal failure. Okay? In the mechanical ventilation, again, they insist to use low tidal volume, 6 ml per kg, as a ventilatory measure in ARDS patient, and they highly advocate for prone position. And all of us know that this is the two only factors that make mortality, morbidity changes in ARDS patient. For glycemic control, they advise to control the blood pressure to be around 180 milligram per deciliter, which is equivalent to 10 millimole per liter. And they are highly recommend to start all the patients with sepsis in VT prophylaxis, heparin or Clexane or whatever, but should be started from day one if there is no major contraindication. For protein pump inhibitor and sodium bicarbonate, unfortunately, these two are still very debatable. Most of them, they will go ahead with the proton pump inhibitor, But for bicarbonate, 2-3 studies published in 2021, then in 23, all of them show there is no difference in mortality by using sodium bicarb. Only we are using it to buy more time in a patient with severe metabolic acidosis. So then in April 2024, Survival Sepsis Campaign released the latest update, and it is mainly for antibiotic timing and recommendation. And they are emphasized, this is depending in retrospective cohort study, and they are measuring and evaluating the real time of impact of introducing antibiotic to the management of sepsis. And in that, they recommend to personalize that in the treatment by antibiotic. You should not treat all the patient the same. They divide the patient into 3 groups: patient with septic shock, patient with probably he has a sepsis, and patient with possible sepsis. So in a patient with shock, they advocate to start broad spectrum antibiotic within the first 1 hour of entering the door of ER, not the ICU, not the medical ID. It should be started from the patient arrive to the hospital, and they highly recommend also to take a blood culture if possible before administering the antibiotic. But in case the blood pressure is not possible, you should not delay the administration of antibiotic more than 1 hour to do that. In a probability infection or a patient with a probability infection, they also recommend to administrate antibiotic, but they give you more time for investigation and source control, and they advise to be administered within the first 3 hours of hospital admission. In the possible infection, it is a weak recommendation, but still they recommend that to delay administration of antibiotic even more than 3 if you are not really sure this patient is sepsis. Sometimes the patient will come with like complex picture, heart failure, renal failure, maybe sepsis. So if you are not sure, you can do more investigation, you can do labs, you can do imaging. Once you're sure it is a sepsis, you can start it, but they give you more timing to administer that up to more than 3 hours. Dr. James, do we have time to go to the UK? The problem UK is always special. They never follow anybody. They want to be a pioneer in everything. So they are releasing their own recommendation. Do we have time or shall we stop here?
2 minutes.
Okay, so I will go fast. It is big articles published in October 2024. And by the way, WHO also recommendation in January 2024, they start to do their own recommendation, and the WHO recommendation will be released approximately in the mid of 2025. So in UK NICE sepsis guideline, according to the antibiotic, they are emphasized to better targeting antibiotic to those at high risk of suspected sepsis, and they are advised to use NEWS2 rather than using QSOFA, and the system help in determine the severity of disease and give more opportunity to the doctor to decide that. Regarding antibiotic, for patients with high risk of sepsis, the standard continue to push for antibiotic administration within 1 hour, following status of the patient, and if he need more, you will give him more. So the oxygen therapy, the patient with sepsis often experience hypoxia. They are requiring oxygen supplement, and the goal is to maintain the oxygen saturation between 94 and 98, and usually the oxygen therapy can prevent organ failure. They found that treating early hypoxia can result in reducing the risk of developing organ failure. The use of vasopressor, again the recommendation almost the same. They advise to start noradrenaline as soon as possible to maintain MAP above 65. In the case of refractory shock, which is again, if not responding to noradrenaline, vasopressin can be added, or adrenaline. In Survival Sepsis Campaign, they are pushing more of vasopressin. Here they are giving you the choice to take one of these. As we know, all these are guidelines, and as a physician, as a consultant specialist, we need to individualize our decision according to the patient preference. Like for example, if I have a heart failure patient and he has doubtful between overloading, I will use the dobutamine maybe or adrenaline instead of vasopressin as a first line. So again, it is just a guideline, and you have to individualize it when you are treating your own patient. So for supportive care, again, it is the same recommendation, 180 milligram per deciliter or 10 millimole per liter. And again, venous thrombosis prophylaxis should be administered in all patients who is presented with sepsis. Thank you for understanding, and if you have any questions later, thank you very much.
Thanks.
Thank you, Doctor, for the informative session. So to introduce our second speaker of the night, I would like to call upon stage Dr. Pratik Agrawal, Specialist General and Laparoscopic Surgeon. As a laparoscopic surgeon, Dr. Pratik performs advanced surgical procedure with a high quality and safety standards. He has over 17 years of experience in minimal access, bariatric and GI surgery, and holds fellowship in these fields from prestigious association. Welcome, sir.
Thank you. Welcome to the CME and emergency and critical care. It is my pleasure to introduce Dr. Mithun C. Mohan. He is a distinguished specialist internist with over 11 years of experience in the field of internal medicine. His academic journey began in Calicut Medical College in India, where he finished his MBBS, and then after that he went on to do his masters in Pariyara Medical College. After that he had 3 degrees from UK, MRCP, MRCPS and FRCP from Edinburgh. He has his vast experience in managing complex multi-system diseases. His main expertise includes diabetes, hypertension, thyroid disorders, infectious diseases, rheumatological diseases, critical care, and has special interest in allergic and lung diseases. Dr. Mithun is not only an exceptional clinician, but also a passionate academician. He has numerous publications and is mostly invited to all national and international medical conferences. Please join me in extending a warm welcome to Dr. Mithun C. Mohan.
So most of the things Sir has already explained to you regarding sepsis and multi-organ dysfunction goes hand in hand. Because many of the times we feel that it may be related to sepsis, but what I will be throwing a highlight will be on other few causes which can cause multi-organ dysfunction as well. So what we call here systemic inflammatory response syndrome, that is triggered by mostly sepsis in almost 70 to 80% of the cases. And what happens is that it leads on to organ damage, where there will be endothelial damage, there will be patients who are having cardiac issue, hyperperfusion of tissues, which will lead from one organ affection to the other. So that is what we are going to consider now. As I told you, the primary most important factor is sepsis. But otherwise, we do have immune mediated. This is something which we always have to keep in mind. It may not be always sepsis, but the immune mediated reflections of vasculitis as well as other cases can also be one of the reasons. And cytokine response is the key factor of what is happening, like the interleukins and the cytokines which are reflecting on the body immune system. That might be one of the reasons which can trigger the organ damage. And most important, recently we have seen cases which are mentioned as IgG4 related diseases, like especially presenting like pancreatitis and then going into SARS. So the key point of treating such patients is age-old discipline of identifying early sepsis. And as told in his presentation, there are scoring systems where we have the QSOP, where we have the National Early Warning Scores. And most important thing is that the documentation and serial documentation, I would like to stress on that point, serial documentation of the respiratory rate, oxygen saturation, systolic BP, pulse rate, level of consciousness, or if the patient is going for a confused state in the ICU, or delirium, and temperature. These are the key factors which will guide us to identify early sepsis and to prevent multi-organ dysfunction. Now, multi-organ dysfunction, whenever we have two or more organs affected, we call it multi-organ dysfunction syndrome in a patient, and that progressive organ dysfunction is usually happening in an acutely ill patient or in an acute and chronic case. Acute and chronic case in the sense like it can be a rheumatic disorder or it can go into a complete full-fledged inflammatory mediation. And the ultimate first identifying factor will be that the homeostasis is not maintained. Mostly it will be primary or secondary, and you can see that the perfusion, organ perfusion, like what has been explained right now in sepsis, the MAP goes down, the mean arterial pressure, and that leads on to the trigger of multi-organ dysfunctions. Now, organ function monitoring, what are the key organs what we are going to monitor is renal, we all know that, hepatic, cardiac, pulmonary, brain, as well as circulatory functions, and muscular. Why I specifically mention muscular is because I present a case scenario in the end of the presentation, because there are multiple muscle enzymes which can lead on to multiple organ dysfunctions. So that one, renal, hepatic, cardiac, we all do know that, we all do monitor. But mostly please, one more thing is that the others, even the skin also. Like we have heard about the Stevens-Johnson syndrome as well as toxic epidermal necrolysis and other things. This all can go into multi-organ dysfunction. So, when I was preparing this topic, there are some few tests which I was just referring to, like what is new in multi-organ dysfunction. And one which was recently being highlighted was the presepsin. Presepsin is a marker of sepsis as well as multi-organ dysfunction. It's not widely available in the market right now, but hopefully, inshallah, that it will come sort of slowly. And procalcitonin, this is one of the markers where it will decide whether it's an inflammatory response like a rheumatic issue or a IgG4 related disease, or it can be related to an infective disease. So procalcitonin will give you a clue of the prognosis also. And that is something which is very helpful. The other few molecules, what we have recently identified for acute kidney injury, for prediction as well as for protecting the kidneys, will be the kidney injury molecule 1, interleukin 18, and the neutrophil gelatinase associated lipocalin. These are tests, again as we told, these are all tests which we are waiting to be widely available in all our laboratories. But to identify, to know that what is the usefulness, it's always as an academician, it is always beneficial to know about it. Now, pro-BNP, this is something which I wanted to highlight because a heart failure patient who is going into hypertension, is it related to a cardiac or something else or a sepsis mediated, the pro-BNP will give us the better clue because troponin when we are doing, in sepsis troponin I can go false positive, D-dimer can go false positive. So pro-BNP will be giving a better clue of whether it is a cardiac failure which is leading on to multi-organ dysfunction. And definitely yes. Whenever we take the patient, obviously multi-organ dysfunction patient will end up in the ICU. We have to give the critical care, and like what we are doing right now with one of our patients, we need to have a full-fledged team. It should be like a multidisciplinary approach. So multidisciplinary approach to a patient who is entering into ICU with multi-organ dysfunction, nephrologist, cardiologist, intensivist, internal medicine, or hepatologist, everybody will have to play their own role in multi-organ dysfunction. So identifying the core team and engaging the core team will be the most important factor what I would like to highlight. And why I mentioned ABG is because this is one of the simplest clue which will give you whether the patient is deteriorating or not. And ideally when the patient is ventilated, this has to be done once in 12 hours or once in 24 hours, as long as the patient is not stable. So arterial blood gas and not the venous blood gas. I always prefer to have arterial blood gas rather than venous blood gas because arterial blood gas gives you more identifying clues on the O2 levels as well as the saturation and lactates. Now, management, as I mentioned, it is always going to be in the ICU. There is not much of discussion about it. There is nothing latest in it. From decades, we have been managing multi-organ dysfunction in ICU only. And supportive care, as I mentioned, we have to identify the renal, hepatic, cardiac, as well as hematological. Hematological, one of the important factors what I wanted to highlight was we have to regularly monitor the platelets as well as the coagulation profile of the patient also, because that also can go deranged, which will end up in complications, because when we are dealing with multi-organ dysfunction, that is something which we should not overlook. Brain, obviously, yes, we need to have the brain perfusion and respiratory, especially to recollect the age-old scenario of ARDS. We need to make sure that we give the correct peak, engage the intensivist, and make sure that we are giving a proper oxygenation where the oxygen saturation levels have to be monitored in sepsis or multi-organ dysfunction. Now, taking it, I have very limited time to do that, I don't want to extend it too much, but just let me go through an example which I wanted to highlight. We had a patient who came to an emergency with only hypotension identified, and a patient came with PDS. So the BP was going down. It was 70-50 initially, then it went down to 60-40. So we identified that the patient is going into for a shock. Took the patient to ICU, and the first initial things were we had a patient with this one, like renal and hepatic dysfunction. And one of the key points was that because of their lifestyle, we had a drug toxicity screening, which has to be also be kept in mind when you get a patient with multi-organ dysfunction, because drugs toxicity, apart from immunomediated or infections, are also one of the reasons, and which we should not overlook. And that came positive. And most important thing was that the CPK levels were sky high. The CPK levels normally should be less than 197, and this patient had a CPK level of 42,000. And that was the key mediator which was causing the renal damage and the hepatic damage. So why I presented the case scenario was because of that whenever we get a patient, we have to always identify, first go with the diagnosis, the root cause analysis, and then manage. The management of multi-organ dysfunction is mainly supportive, and that we all know. as a team, we have to be supportive for that, and the only recent advances are the guidelines where we can identify it early in multi-organ dysfunction when there is sepsis or immune-mediated. And inotropes, dialysis, supporting care, and even now there have been discussions happening with acute onset of transplants like hepatic and kidney transplants and even cardiac transplants, which are being discussed in sepsis or multi-organ dysfunction syndromes. So that's all what I would like to discuss with you. Thank you.
Thank you, sir. Thank you for the wonderful session. So to introduce our third speaker of the night, I would like to call upon stage Dr. Dintu Matthew. She is very versed in managing acute emergencies. She is proficient as a family doctor providing compassionate care. She is keen to update her medical knowledge and skills. Welcome, ma'am.
Thank you. Good evening all. Let us continue this excited journey within the ICU and critical care. I'm so happy to introduce Dr. Adila Shader here. She's a specialist anesthesiologist and she has a vast experience of 16 years experience in cardiac anesthesiology, ICU and critical care. She started her medical journey from Government Medical College in Alappuzha in Kerala, and then did her MD in Calicut Medical College, and thereafter FNB in cardiac anesthesia from Narayana Hridayalaya Reputed Institution in Bangalore. She is also Secretary Fellow in ECMO and Cardiac Critical Care. She is a honorary member of MNAMS and esteemed member of Fellow of Indian Cardiac Anesthesiologist. She has worked in many renowned institutions back in India as well. In Oman, she was a team member of cardiac anesthesiologists in Royal Hospital and currently with us in Bangalore Royal Hospital. We welcome you, ma'am.
Good afternoon all. It's a brief talk on assessment in the ICU. Am I audible?
No better right.
Sorry for the time taken. It's a very vast topic. I try to debrief it. The volume assessment in ICU. So why is volume assessment in ICU important? All of you sitting here know it very well. We have worked in the emergency departments, the ICUs, the dialysis unit. So we have the conventional methods of the volume assessment, which we all of us have practiced right from the med school, like mucous membrane examination, capillary reliefal, skin turner, the jugular venous pressure, the lung examination, and the chest X-rays. Just a diagrammatic representation of, I hope I'll explain it. The mucous membrane, whether it's dry or moist, coming to the lungs, depending on the chest X-ray, whether you have pulmonary condition, based on the lung ultrasound, whether they are curly A or B lines, depending on your IJV, whether you have distant IJV or a hepatojugular reflex, coming to the heart, where nowadays you have the transthoracic focus, the ES the ventricular size, the transient blood place, systolic suppression, come to the skin turgor, and finally the peripheral edema, which can be often convincing, but peripheral edema may also occur due to other reasons other than failure. So we have biomarkers clinically. As told by the previous speakers, we have the BNP and the serum CA125. BNP anything more than 100, let's say 50 to 100 pg per ml should be taken care of. Maybe it's a pro-runner of cardiac failure, sepsis, MODS, CA125 depending on the condition and the status of the patient. Yeah. So most of us know that we take the BP, the mean arterial pressure, as the end point for resuscitation. See, that's what we have been taught from the very beginning. So that actually is not the state of art. There are points and things beyond that which needs to be taken into consideration. For example, the serum lactate that comes in the arterial blood gas or the venous blood gas, anything less than 2 millimoles per liter is fine. The patient is hydrated, you're having a great patient. Now something else is coming which is called the mixed venous oxygen saturation, the SCVO2, which we get with the pulmonary artery catheter, which I will come to later. And also something called the systemic stroke volume and the cardiac output, which can be monitored by the central line, the pulmonary artery catheter, the arterial pulse line, the thermodilution method, and various other methods like stroke volume variation, which I will just brief it. So this is the basic diagram. All of us know cardiac output is heart rate and stroke volume. So it's our body is like a bottle, you know. You give the water from above. We get the bottle, we get the water right in our right atrium through the SVC, it goes into the right ventricle, it's like the engine running, and that goes into the lungs, and then it goes into the LA, the LV, from the LV, the cardiac output is pumped out to the entire body, again running a whole cycle. So the only external source is the water you give from outside, which has to be calculated and moderated. So cardiac output monitoring basically. We have the invasive methods and the non-invasive ones. The invasive methods are the central venous line, the pulmonary artery pressures. The non-invasive ones are the echocardiography that we use, the transthoracic and the transesophageal echocardiographies. We have the esophageal Doppler for that matter, and also various other terms like PICO and LITCO. It's lithium analysis as well as arterial pulse pressure analysis. CVP, as I've told before. So before you know what to do, you should know what to attain. So these are certain numbers which you need to know. Let me just try to make it simple for you. The end diastolic volume, that is at the end of diastole, what do you have in your left ventriculus blood? It gives out to our body. So roughly it should be 120 ml. End systolic, the next one. It is not a very important number, but it's roughly half of end diastole. The stroke volume is roughly as same as end systole, 60 to 70. Stroke volume index is stroke volume divided by the surface area. The EF, that is what everybody, looks at when you get an echo report, 55 to 70. But let me tell you, it can be a misnomer because in cases where you have regurgitant lesions, you have combined heart lesions, the EF may be exaggerated. If the EF is somewhere like 40, 35, with MR, AR plus a tricuspid valve disease, you may even have a EF of 70. So do not go into it just by that. You need to have knowledge of whatever happens in the patient's anatomy other than the EF. Now, as you all know, cardiac output, that's somewhere from 4 to 8 liter per minute per meter. This criteria, this cardiac output, is something which we measure through our central venous line, pulmonary artery catheter, arterial pulse pressure, the cardiac index. Whatever index comes is the output divided by the area. The SVR and the PVR just terms to know. So let me first go to CVP. So central venous pressure has been taught to put central arterial lines and central venous lines. But let me tell you, anything like it is 8 to 12 mm of mercuries. But it all depends on how the patient is. Whether the patient has got a right-sided heart problem or a left-sided heart problem. For example, central line, the tip of the central line goes into the right atrium. So the fallacy with the central venous line is that the right side of the heart, it is actually thin wall, the right atrium. They call it the weaker brother of the heart. It is more compliant. So if you give it a little more volume, it will go on filling. That is, it is like a balloon. It will tend to distend. It can distend unless and until then it goes in for a rupture. Like you have RBMI where there is a sudden hypotension, because it is compliant. It can hold. It will distend and suddenly drop point will come. But the thing is that there is something for the left side which is much more important, because it has got stronger walls, more compliant. The LV will resist failure for a longer time than the right heart. So what you are looking at with the CVP is only the right side of the heart. That is the right atrium to be precise, which can be very often misleading, because you may tend to overfill, it can hold, and actually the patient may not need that much of fluid, which the left cannot handle. So let's go a step above, beyond CVP. Okay, so there are some waves, I'm not going through them, just P waves, which corresponds to the A wave, that is the atrial contraction, the QRS complex, where there is bulging of the right atrium, the tricuspid valve into right atrium, giving the right ventricular contraction, and then you have the X descent, and then you have the Y, which is the relaxation of the atrium, right atrium again, and Y descent, which is the let of the blood from the right ventricle. It's all a pattern in the right side of the heart that is related to CVP. Certain conditions, I just want you to look onto the abnormal sides. Atrial fibrillation flutter. What we have been taught is there is no P wave in atrial fibrillation flutter. So P wave corresponds to A wave. In the CVP, there are no A waves that you can see. AV dissociation. There is no communication between the atrium and the ventricle. That is, you have huge A waves. That is electromechanical dissociation. Tricuspid valve. Tricuspid valve is the valve which is present in between the right atrium and the right ventricle. So the problems associated with the tricuspid valve, whether it be insufficiency for that matter or stenosis, is associated with a giant V wave or a giant A wave. And then restrictive cardiomyopathies. Any kind of tamponade or restrictive cardiomyopathies, the descents will be very steep. There are two descents, X and Y, they will be very steep. The other part, the ups, will be very high. Now I'm going to pulmonary artery catheter pressures. Pulmonary artery catheter, which is a favorite of mine, because invasiveness and interpretation played a great role in PA catheters. Now we are a step beyond that. We've got modified PA catheters, where in ICU we get continuous cardiac monitoring due to these PA catheters, and we have many a point save the patient's life, able to wean the patient from the ventilator, take the patient to dialysis with the right mode of dialysis. So they call it I'll go through it first. They call it the long yellow snake. You can see the color is yellow. It's long because it's 110 centimeter. The CVP is 13 centimeter. This is 110. The French is the same. The width is the same. 7.5 in adults, 5.5, 3.5 in the pediatrics. For pediatrics, we never do this. Has been associated with ventricular rupture. So what happens here? This long snake will go from the right side to the left side of the heart and measure the left side pressure. So I'll come to it. Let me just simplify this for you. There is a balloon. It is called the balloon flotation catheter. This balloon is inflated. That flows along the blood from the right side to the left side. And this is what you see is the heating filament, the thermal filament, the oils that you see. This gets heated as it passes through the volume in the heart, which measures the cardiac output by floating against the curve. After 110 centimeter, you have got many ports. This can be for connecting iodomes, for pacing ports, for distal injectate head. Even dialysis sheet can be passed through this. Oh, this is a video. Let me just give a demonstration. I will be very quick. I'm sorry I'm taking a long time. Yes. first what we do is the snake has entered the right atrium via the SVC. This is the IVC. And then in the identified-ish place, it is going via the base forms. For example, this is the right atrium. You can see the right atrium, the C wave. This is the wave. So, it's like a CVP wave here in the right atrium. And this is the right atrial pressure, 0 to 8. That comes, these are the markings. So you can see it's something below 10. And this is the wave that you get. So it is somewhere in the right atrium. Now, when we go beyond, yes, the balloon has been inflated. It is inflated once we get the CVP trace. This is our tricuspid fellow. It has traversed it, gone to the right ventricle, and then what you see is it's going to the pulmonary artery. This is the pulmonary artery. So once it enters the pulmonary artery, this is the, there is the notch, like the arterial pulse tricortic notch. You can see the pulmonary artery pressures, which are 30. Systolic and diastolic 50. Pulmonary artery pressures anything more than 30. You suspect that there will be some kind of pulmonary artery hypertension. This can be inserted via the femoral route, the subclavian route, the IJV route. The femoral is good enough if you have a lot of other inotropes running through this. Yes. So, what does the PA measure? It measures the cardiac pressures in each chamber, the PA pressures, the oxygen saturation, the mixed venous oxygen saturation they call it, because it is not the arterial oxygenation, it is the mixed blood, venous and oxygen. That determines how much of desaturation your heart can hold, and that is what is important. It is not how much you have, it is how much less your heart can tolerate. So this oxygen saturation is actually mixed venous oxygen saturation, the normal value is 70 to 75. This is what they call the pulmonary artery catheter, is also called the Stan-Squams catheter for measuring the pulmonary capillary wedge pressure. Once it is wedged into the pulmonary capillaries, they call it the wedge pressure. So it's the same pressures that we mentioned, like this will be the PA pressure, this will be the RV pressures, this will be the pulmonary artery capillary wedge pressure or occlusion pressure, since the balloon has gone and occluded it. Each pressure in each chamber differ. According to these values, we give the fluid. Yeah. So this is it. The right atrial pressure, you can see the, yeah. So the right atrial pressure, you can see it's in the right atrium. Yeah. It's in the right atrium. What you can see is this CVP trace, RA pressure trace, very similar to the trace of the pulmonary artery wedge pressure. You can see this. See, you know that you're either in the RA or you're fully into the PAW. Yeah, I'll make it fast. The RVP pressure is like a long one, and there's a dichotic one if there is a PA. So you get the left-sided preload, the left-sided pressures, and the oxygen consumption. There is a thermodilation technique useful for this, that is cold solution is injected into the atrium, which causes blood temperature drop because it's a cold solution. And the thermistor in the thermal filament of the BACW measures the change and records it under the area under time graph. Even lithium can be used, they call it the indicator radiation method, which is used. And this comes into play, it is called the Stewart-Hamilton equation. He is the father of the pulmonary artery catheter. This is the area under the curve. Fixed principle used to use in the good old days, modified over that. So these are the traces and the measurements we did. Hypovolemic, tachycardic, heart rate 90, cardiac is 4.5. Normovolemic, heart rate is normal, 76, cardiac is normal. These are the values which come onto your monitor. You do not do anything. The catheter is connected to the monitor, you get these. That's the beauty of it. Now the last part of it, the radiology. This is the in thing now. You have many kind of plots. The one which we use are the low frequency ones. See, only you have to concentrate on this. These views are named depending on where we place a drop. It's very simple. You just have two views. It is kept parasternally in the long axis and apically or substernally. Let me make it very, very smooth for you. This is the parasternal long axis. See, this is the left atrium to start with. The mitral valve, the left ventricle, which continues into the aorta, the Namaste sign. And here is the right. If you have a pericardial effusion, you get a very dark shadow over here. So that is this view, the first view you do. This is in systole and diastole. In systole, what happens is the blood is ejected from the heart. So the valve is open, the aorta is open. In diastole, the blood is in the heart, the aorta is closed. So you know how much it opens and how much of flow is going inside. This is the short axis view. Drop kept parasternally, the second view. See, the thing that's staring at you, the circle is the LV. It's a big brother. The RV doesn't come into view much. If the RV comes much into view, that means it's dilated. And you have a septum. The septum is usually C-shaped. If it is protruding more to the RV, then you know that the LV is getting more filled. Okay, the numbers. Let me just tell you this. The LA diameter, this is the 4-chamber view. You can see the 4 chambers. The one down is the LA. Anything more than 4.5 should ring alarm. And equally important is B. See, this is the aorta, LV, LA. So the left ventricular diameter in the diastole. Anything more than 5. So anything more than 5 in these two views should ring a bell that yes, we are doing it more. Now the IVC diameter. See, IVC diameter, anything less than 2 is fine, and you should have a 50% variability with expiration and inspiration. This is how you do it. This is, you keep a subcostal view. This is the IVC, this is the liver, this is the SPC, this is the hepatic vein. Put a M more through it, and you get like the maximum width you will get, the minimum width you get. The maximum will be the inspiration, let's say 1.35. The minimum will be expiration. You apply it as a formula like this. Expiratory, inspiratory, by expiratory. You get something like 50, you're okay. If it's more than 50, also okay. Less than 50 means your IVC is dilated. This is it. 50% inspiratory reduction. Less than 2%. IVC diameter. For this, it looks okay. You here see that the diastolic diameter, the cardiac chamber is enlarged. Even in this transgastric view, this is the LV view, we can measure and find out the numbers. 3.5 is significant. Yes? So, the same thing. The red signs are one moment. A dilated LV, a dilated heart chamber, a D-shaped LV, and something which I should tell you is the curly A and the curly B lines. So it's not moving. So I'll just go ahead with that. Curly A lines, they are normal lines, you know. So we've got to stop. Yeah. So curly, I'm not getting it on the frame, I'll just mention this. Curly A lines are the normal lines that you see. Curly B lines are the curly lines. I'm talking about lung ultrasound. Anything less than 2 number of curly B lines is okay. Anything more than that shows that the reverberations of the fluid are accumulated in the lung. And also there is something called seashore sign and a barcode sign. Seashore sign in the lung shows that your lung is fine. But if you get a barcode sign, I would like to show all that the video is not working. But if it is a barcode sign, then you know that you have a pneumothorax. So you just have to look at 4 things: curly B lines, seashore sign, and barcode sign. I'm sorry, after the videos are not working fast enough. So that's it. My disclosures are done, and my references are many. And thank you all for listening to me.
Presentation. So moving on next, to introduce our last and 4th speaker of the night, I would like to call upon stage Dr. Ilham Ahmed. He is a highly accomplished pediatrician with over 2 decades of experience in pediatric and neonatology, coupled with a distinguished academic career as a professor of pediatrician. Welcome, sir.
Yeah. So, thank you all for the wonderful evening. And the next topic is a very interesting topic. It's one of the major decision makers in ICU care, and that we have an apt and adept speaker for the day, and he is Dr. Jaishankar. A short profile of him. He is an alma mater of Amrita Institute of Medical Sciences, and 2 points if I say of him. You give him a difficult case, he's too happy to do it. Cases which are refused from other places, he's too happy to do it. And he's apt for the topic which we are going to talk about. More he will speak. Thank you. Invite Dr. Jaishankar.
Good evening all. If I say about weaning, you all will be thinking about dinner, I know, at this point of time. So, unfortunately, the weaning time, excuse me. So the weaning which I will be talking about is weaning from mechanical ventilation, and my topic is diaphragmatic thickening fraction and diaphragmatic excursion, which is used as an assessment tool in weaning from ventilation. So why is it relevant? I'll say we get all patients, most of the time we encounter critically ill patients who require mechanical ventilation in ICUs, but when the condition is recovered, we would like to take him out of ventilator. So taking the patient out of ventilator at the right time is a key in reducing the mortality. There are many parameters which helps us in doing that. Clinicians' clinical judgment is the most important one, but we often tend to, for research purposes and for making it documented, we have to use many other parameters as well. And post-operative, in most of the patients who are mechanically ventilated for more than 6 hours itself, the changes in the body will start to happen, and with each day of additional mechanical ventilation, it is said that there is decreased diaphragmatic force generating capacity, and the diaphragm thickness is also reduced, and some say it is up to 6 to 7.5% for adults and 2 to 3.5% for pediatrics. The reduction in thickness of diaphragm. Thank you, sir. So the diaphragmatic dysfunction, which is a loss of partial or complete muscle power, which results in decreased inspiratory capacity or impaired respiratory muscle endurance. And when do we know that the patient is ready to be weaned off ventilator? It is when the reversal or improvement of the condition, or when the FiO2 is less than 50%, and if the PEEP is less than 5 to 8 centimeters of water, and when the ABG values are normalized and hemodynamically stable, in presence of spontaneous respiratory drive and with minimal or no sedation. The cause of diaphragmatic dysfunction can be ventilator-induced diaphragmatic dysfunction or sepsis-induced diaphragmatic dysfunction, and it is mostly associated with some oxidative stress or mitochondrial changes, or changes in the protein turnovers, which results in proteolysis, which eventually turns up as atrophy or decrease in respiratory muscle contractility. So, weaning assessing parameters, when the patient is ready to be weaned off ventilator, we do some standard weaning criteria, manuals are there, which evaluates the patient's respiratory muscle strength and endurance. And the first step is to put the patient in the spontaneous breathing trial when the patient satisfies the previous these parameters. So the spontaneous breathing trial is set when the patient breathes with minimal or no ventilatory support, or with very minimal inspiratory pressure support. The successful spontaneous breathing trial is when the patient is able to breathe for 30 to 120 minutes. The other parameters which helps us in assessing, predicting a good weaning outcome is the rapid shallow breathing index, which is frequency by tidal volume in liters. So it depicts the relationship between the respiratory load and the muscle function. And the value which is said to be less than 105, that is the respiratory rate divided by tidal volume in liters. If it comes to less than 105, it is considered as a good predictor for weaning. Another parameter is the negative inspiratory force, or the maximum inspiratory force, which is said to be minus 20 to minus 30 centimeters of water. And then maximum expiratory force, which is considered as 60 centimeters of water, is a good predictor, which helps the patient in clearing up the secretions from the body. And total occlusion pressures at 100 microseconds, which is a negative pressure generated by the patient against an artificial airway at the initial 100 microseconds of the inspiratory effort. And there are many other integrated indices. CROP is one among them, which takes dynamic compliance, respiratory rate, oxygenation, and inspiratory pressures. So the CROP value less than more than 13 is considered as a good predictor of weaning. In addition to all this, we have ultrasonography, diaphragmatic ultrasonography, wherein we evaluate certain parameters like diaphragmatic thickening fraction and diaphragmatic excursion. These also help, in addition, it helps in increasing the sensitivity, specificity, positive predictive value, and negative predictive value of assessing the in successful weaning. So diaphragmatic ultrasonography is considered as it's the only real-time bedside tool which can be used, which is repetitive and affordable, which along with the other parameters which I explained earlier, increases the sensitivity of positive outcome in weaning. Diaphragmatic thickening fraction is measured by the diaphragm thickness, also measured by a linear probe, high frequency linear probe, which is kept in the 9th or 10th intercostal space in the anterior axillary line, perpendicular to the intercostal space. It is kept at the zone where the diaphragm reaches the rib cage. So, as in the diagram, we can see two hyperechoic areas between the rib in the intercostal space. The first one is the pleural line. The first one is the pleural line, and the lower one is the peritoneum, and in between is the diaphragm. So, with each breath, at the end of inspiration and at the end of expiration, the measurements are measured and evaluated, and that can be depicted into diaphragmatic thickening fraction, which is thickness at the end of inspiration minus thickness at the end of expiration divided by thickness at the end of expiration into 100. So that is the diaphragmatic thickening fraction. These are the images of left and right hemianal diaphragms. The normal value of the diaphragm thickness is 2.4 plus or minus 0.8 millimeters, and if we can say that the patient has started diaphragmatic atrophy if it is less than 2 millimeters. So diaphragmatic thickening fraction less than 20% is considered as diaphragmatic dysfunction, and more than 30 to 36% of thickness fraction is a positive indicator of successful outcome in weaning. Next is the diaphragm excursion. For that we use curvilinear probe with 3 to 6 megahertz of frequency, which is kept at the subcostal area, directing towards the posterior third of the diaphragm, so that when the patient breathes, the diaphragm moves towards the probe. And M mode is used to measure the diaphragm excursion, and we keep the scan line along the perpendicular to the diaphragm, so that it can assess the distance which the diaphragm travels. Diaphragmatic dysfunction is diagnosed if it is less than 10 millimeters or if there is any paradoxical movement. For the normal tidal breath, if it maintains around 11 to 14 millimeters, or if it is more than 30 millimeters in a deep breath, we can have a good predictor for positive outcome in weaning. So, diaphragmatic dysfunction can be assessed earlier, and the involvement of diaphragmatic thickening fraction and diaphragm excursion by diaphragmatic ultrasonography, along with the other modes of weaning, which helps in improving the sensitivity, specificity, positive predictive value and negative predictive value of successful weaning outcome. Thank you.
Thank you, sir. Thank you, doctors, for a wonderful session. So now the forum is open for the question answers. Anybody is having any questions related to the topics?
Thank you, speakers, for such wonderful presentations, and the topics selected were great. And as it is very obvious, the strength of the institution is measured by how well the emergency patients and critical care patients are managed. So I think the floor is open for questions. Anyone? I have a few questions. I'm not a physician. I'm not an anesthesiologist, but some queries can always be there. The first question or rather, my curiosity is to Dr. Ahmed. Is there a clear-cut time when you say this is suspected sepsis versus actual sepsis? It's a shock, actually, septic shock.
The only difference. So the difference between sepsis and septic shock is the patient clinical condition. Like if the patient MABS is below 65, that means he is suffering from hypoperfusion. And usually hypoperfusion will lead to end organ damage. And once the end organ damage happens, this is what we call septic shock. And this is like any other shock, like cardiogenic shock, like neurological shock. Any shock means there is hypoperfusion, and because of that, the end organ damage will happen. So it is more of evaluation and the clinical condition rather than any specific line of factors.
So is that assessment very objective, or it could differ between two persons?
Most of the time it's very objective because it is measurable by most likely by MAPS and by lactate level. But the difference between sepsis and severe sepsis in the previous survival sepsis campaign was like objective. It depends on the patient depends on the doctor who is examining. But usually a septic shock will be very obvious. There is hypoperfusion, there is a bit like high lactate. All these will direct you to hypovolemic shock or whatever septic shock.
Just one more. Yeah. How do you decide the broad spectrum antibiotic? I mean, is there a guideline or?
There is no specific guideline, but in the first broad spectrum, we need to cover almost gram-positive, gram-negative, aerobic, and sometimes antitoxic, it depends. But it will go with a hospital guideline and the infection which is more common in the community and in the hospital. For example, if I receive a patient with community-acquired pneumonia, I need to cover atypical. If I receive a patient plus the normal broad-spectrum antibiotic. But if it is hospital-acquired, we need to cover more of CRE, MDRO, and VRE, sometimes MRSA. So it depends on the prevalence of the infection in the community and the hospital. So there is no specific antibiotic choice for that.
So what is the most common antibiotic that you use?
Nowadays in the hospital, in the ICU, we'll start with, like, if it is pneumonia, we'll start also, it depends on the type of infection, like UTI different than pneumonia. But in pneumonia, usually we'll start with ceftriaxone and we can upgrade it to tazocine. And sometimes if the patient was in the hospital for a long time, we can add vancomycin to it just to cover the MRSA.
Thank you. Any questions coming up? Please stay. Yeah.
Thank you very much for this very benefit presentation. I will ask about, there is no benefit of sodium bicarbonate, mostly,
yes,
for patients with this. When you recommended to use CRRT or any kind of hemodialysis to correct?
Usually CRT. CRRT, usually there is a specific criteria to start the patient on dialysis, whatever the mode of dialysis. The difference between intermittent hemodialysis and CRRT, that hemodialysis with CRRT is a bit uncompromised uncompromised patient vascular and patient cardiovascular system. So we are using slow dialysis. But the criteria is very obvious. Any metabolic acidosis with a pH of lower than 7.1, it is an indication for dialysis if it's not responding to initial resuscitation and using of vasopressor. The second one, hyperkalemia. The third one is like a patient with severe distress and overloading because of heart failure or something. We can also use CRT or any type of dialysis. But in sepsis, septic shock, mainly severe metabolic acidosis plus hyperkalemia.
Thank you, Dr. Ahmed. Just one curiosity with Dr. Mehta. You spoke about pre-sepsis. Can you tell a little more about what exactly it is?
Pre-sepsis is a marker where we will get the identification of early onset sepsis. So it's just recently being updated in articles. So not widely available. I don't think that it's available in online right now. But slowly it will start coming up as just like procalcitonin. 5 years back we never had procalcitonin here. But now we are getting procalcitonin in 1 day. So pre-sepsis is something which is going to give you an early identification of sepsis.
Just one last comment about Dr. I don't think during your last slide, the speaker was pushed out by the moderator. Yeah. I think moderators. Just one thing. Who does this test? This
Diaphragm ultrasonography.
this is the residentist or the cardiologist or the radiologist?
The critical care physician usually does that. It's part of our armamentarium now. So we have ultrasound in almost all ICUs. So we can use it with all the patients who are mechanically ventilated. We can check the diaphragm dysfunction. Can be used along with the other modalities, and before weaning off. It is a repetitive one. We can repeat it at any point. We can serially evaluate if there is any diaphragm thinning, how the thickness is, and we can assess that.
Thank you.
Thank you, sir.
Davis, you want to- any other question, please? With that, I think.
No more questions? I hope the session was clear to everyone. As we can see, no more questions. So to wind up the session with a word of thanks, I would like to call upon stage the branch head of Vadrasama Royal Hospital, Mr. Rajesh. Welcome, sir.
Good evening, doctors, dignitaries, and management team of Vadrasama Hospitals. I would like to thank all of you for gathering here on our invitation on, I hope, the interesting topic we have selected. And as our CEO in our introduction mentioned, Vadrasama Royal Hospital is commenced with the 6th center of excellence we are planning, and already there the gastro, the urology, the orthopedics, the ENT, the mother and child, and the emergency. Now, of all these topics, 7 topics, 6 we have covered. Now the left out is the mother and child. So we'll be soon arranging a topic on the mother and child as well. And I would like to thank the speakers, Dr. Ahmad, Dr. Mithun, Dr. Jayashankar, and Dr. Adina, and also the moderators, Dr. Subhendra and Dr. James as well. Thank you, doctors. Thank you for the gathering. With this small note, I would like to welcome you all to break for the dinner. Thank you. Have a good night. Thank you.
One more thing before leaving, can we have a group picture, please?
Yeah.
Whoever is available with the speakers, can we have a group picture? No, everybody. Please join us for a picture.
Doctor, please.
I think we need to make a work. Please sit down. Who can sit down?